Hello, everybody. We're all getting let in. I'll give just a minute for everybody to get in. You got them all in, Jordan? Yes. Okay, everybody from the waiting room, and we'll let people in as they come. Um, Thank you for attending today to our webinar. Um, to maintain security and also to ensure we get correct attendance, and that's the only way you'll get your CEUs. If you could use your name when logging into the Zoom meeting, and you'll need your first and last name. So like I see one that says owner, and there might be some that just have a first name. So if you could change your name to that so we can get your attendance recorded correctly. Um, okay, so thank you for your consideration on that. Adrian, do you want to show
Screen, yeah,
the CEU slide? Is that what you want to start with?
I will. Just 1 second. And can you see it there?
Not yet,
Not yet. 1 second.
not shared.
And I'm going to share it now.
There we go. So today, Adrian Judd Doyle is a nursing academic at Brunel University, London, specializing in prescribing, clinical assessment, diagnostic reasoning, clinical simulation, alcohol health, addiction, and post-registration healthcare education. A former CQC inspector and advanced practitioner in emergency and acute medicine, hepatology, and addictions. Adrian has played a key role in developing and implementing national clinical guidelines for alcohol and opiate care in the UK. His contributions to the NICE guidance on alcohol hepatitis and the RCEM alcohol toolkit highlight his influence on clinical standards. Adrian is president-elect of INSA, serving on various professional committees and works globally to enhance education and resources in substance use and liver disease. He's going to be presenting addictions and neurodiversity, understanding risk, recognition, and inclusive support. Quickly before he gets started, the CME, and here's on the information from Indiana University for the contact hours. You'll get 1 credit hour for this presentation. And again, if you're anybody that just joined us, please have your first and last name on your sign in so we can get correct attendance to be able to give you the contact hours. So please mute your microphone unless asking a question. You can do questions via chat. Jordan and I both will be watching the chat. Turn on your cameras if you please, if you want to be seen. And we will have time for question and answers at the end. And I will hand it over to Adrian.
Thank you, Tonya. So just disclosures before we start. So I'm not receiving any money or anything to do this. This is my own work reviewing some papers and to come out with some potential evidence-based results. The learning outcomes are to explain the relationship between neurodiversity and risk, to look at how individuals who are neurodivergent may present differently in certain environments, and to also look at how to make a more inclusive service. So before I move forward, I just want to make a big acknowledgement. When I planned this presentation, it was 6, 7 months ago, and in the past couple of months, I've started building on it. And very recently, my colleagues in Dublin sent me a very large document regarding a study that they did regarding neurodiversity and inclusion within many countries, but had some big numbers that will help me in this presentation. So, much of my presentation will be alluding to their study together with global numbers. But I do need to acknowledge actually my colleagues in Trinity College in Dublin. So I know on the call I do have Philip, who's here as the INSA president of Ireland, Professor Comiskey, who led on that, and I believe some of my other colleagues will be in here as well. So thank you to Philip and the Irish uh, group to help me in this presentation. So before I read this, I just want to give you a bit of a backstory. So I am a fully signed up member of the Neurodiversity Club. Um, Even that before I was diagnosed, I obviously knew something wasn't quite right. So that led into looking for support for dyslexia, which I got that diagnosis. Again, autism, which is another thing which I think my wife confirmed I had, and even though I had suspicions. And then the final one is ADHD. And with that, I looked at my journey through non-addictions organizations and wondered, why am I having trouble getting through to places? And is that common across a clinical area that I'm passionate about, which is addiction services? I do know that when it comes to intersectionality and all other groups within health, many uh, diverse groups or smaller groups do have challenges. So what I'm saying is this is not a one fix for everything, but I do think having different approaches for individuals that have various backgrounds, medical needs or mental health needs, perhaps is something that we need to do. And I'll allude to that further on in the presentation when I discuss structural stigma. So number one, I want to re-acknowledge Trinity College and my colleagues there and the work that they did in Dublin that gave me a lot of insight into the wider topic. As I said, this presentation uses some of their findings, but a lot of it will be either some of my interpretation or evidence base. And again, I'm not going to be the voice for Trinity, but the key things are that I think they clearly identified key goals such as access, stigma, co-production, and improving integration pathways are needed across addictions agency. So I'm going to focus on that, and as I said, I'm going to allude backwards and forwards to the main topic. So I think most of us are aware of how important language is. And whilst I'm not talking about stigma in as in opiate use stigma and identity that way, when it comes to individuals with neurodiversity, we often like to have our neurodiversity first. So I will always say I am autistic, dyslexic, or ADHD, and that is me. That is whole of me. It's an identity that I have. But I was having a conversation with another person in the room today, and we were talking about person first language versus uh, diagnosis first language. And the thing that we agreed on straight away was actually ask the person where they want to be, because I'm comfortable with my diagnosis and many people actually aren't. And then there are some people who may see themselves as their drug of use more important than their identity. So I think it's really important that we consider that and not go down the route of saying we must treat everyone the same. When we will, the other thing is the data that we've looked at around the world, or Trinity looked at around the world, has got some trends, but I think the important thing to acknowledge is being neurodivergent relies on two things. Either number one, you self identify, or number two, you get the formal diagnosis. And in some areas, getting a diagnosis for a neurodiversity is extremely challenging, with waiting list up to 6, 7 years in the UK now. But also, some diagnosis can be masked. So you are working really well and you don't think you have it because you're surviving, but actually the diagnosis may help you in other ways. So we have a prevalence and comorbidity issue here. When we talk about use of drugs for a neurodivergent individual, I think it's important to understand that perhaps their use may be different than other individuals. I'm saying it could be, but it might not be. And as I said in my introduction, I think it's important to acknowledge that when it comes to services as a whole, health services as a whole, Um, Structural stigma is there. Um, I know in the UK and Ireland, we very much promote service user involvement and co-production when it comes to the designing of new facilities. And that, I believe, has helped in making organizations more open to more people. The only challenge with that statement is, and it comes back to something that many of us in the neurodiversity population say, is if you've met someone with ADHD or autism or dyslexia, you've only met one person with that diagnosis. We do fit underneath that umbrella and we do have various traits, and some of them are more pronounced than others. And so, what might work well for me may not work for others. But ultimately, what we want to do is try and have a system that isn't causing any friction on us accessing services that we may need for a better quality life. The other thing, which I didn't put in here, but I think is really important, the evidence is now saying that individuals with neurodiversity are dying younger than other members of the population. So I only can represent that to what the UK statistics say. We say something such as an individual with enduring mental health is likely statistically die up to 15 to 20 years earlier due to factors, and I'll give my definition in a minute. But now that is coming true for people with neurodiversity. But I think it's important to acknowledge that neurodiversity could be an individual that may have, and I apologize for terminology because it changes around the world, but I would say low support and potentially high self functioning, and those who need a lot more support and have lower levels of functioning. So I think it's wise to acknowledge that we do have a spectrum there. And the other thing to be mindful of is neurodiversity is something that actually people live with, and certain statements like we all have a bit of it doesn't really help because whilst it seems to be quite a popular thing to see on the media, I can honestly say swapping shoes with individuals to spend time with someone who's neurodivergent might be an eye opener. Simple things like before I had a diagnosis of ADHD, I thought, yeah, that's fine, I probably do have it. Day one of taking medication, within an hour and a half, the first thing I noticed was my head is quiet. I cannot hear anything. And so when I spoke to one of my students today who's neurodivergent and we were talking about our journey, we both said that was the most profound thing that we ever experienced. The noise that was normal is abnormal and our heads can be quiet. So I think there is a lot of people thinking they have the condition, but actually masking helps but doesn't help. So I think it's good to have that conversation. So hopefully over this presentation, we'll look at language, we'll look at evidence, we'll look at the structural stigma, and I think we'll look at how we can improve practice. So just some definitions. So neurodiversity is our big umbrella, and we defined ourselves as neurodivergent with some form of development, dominance or hypersensitivity to certain things. So it could be sounds, noises, it could be rigid thinking, it could be hyperactive thought, but not hyperactive motor function. So it combines all of those. There is a big push now to acknowledge that individuals can self-diagnose because they experience it. But I still think now the formal diagnosis perhaps is more important because there are legislations that support individuals. So if I am pushing those people who think or have members who could be or know of people, whilst the waiting list is long and diagnosis is challenging, it potentially can open up other avenues of help. I think the other thing to acknowledge is it comes down to profiles. We look at the neurodivergent profile as in having many different aspects, and you may be high on one and low on another. And in-house, it's called a spiky profile. And I think it's important to acknowledge that what may be high on one individual might not be that high on another individual. So again, yes, it's a statement. Yes, we've all got a diagnosis, but unfortunately, we do present in different ways. And I think it's also important that each one of these diagnoses has different identities. But obviously, for me, having two of these on this page, there's a phenomenon that is, and as I describe, having two children in my life. I have a good child and a chaotic child. I have a child that wants rules, but I also have a child that sabotages, and it's trying to work out and work within that. And the problem is for me, who is sitting here in a privileged position, employed, house, family, etc. There are those people who haven't got mechanisms to work around that. It can be very impulsive. So again, just understand that there are high level and lower levels. And I also think, as I put down here, whilst we are very good at putting a diagnosis to an individual, I don't think pathologizing helps. I think it's important to understand using a strength-based approach. What support can we give? What are you good at for yourself? So I've alluded to this already. The reasons why we individuals who are neurodivergent may use drugs. So I say I don't use illicit drugs. Yes, I occasionally drink alcohol. Can be for various reasons. So it can be for I need to improve my confidence, so I will drink or I'll take drugs. The noise is too loud, I will take this drug. I want to, I don't like who I am, I will do something else. So the actual reason for drug use can change. And often it is because of what they may be experiencing in their normal life. Again, neurodiversity can have overlaps. Obviously, mental health is quite common. There are many individuals who have got trauma that overlaps and obviously is maybe difficult to have any form of control over. But other things are certain things like pain, they have abnormal sleep patterns. And the other thing that I've been reading up now is people with ADHD actually have a big problem when it comes to money. Impulse control is huge. So money that they have in the bank goes in other ways. So they could be cognitively rich, they could be resource rich, but actually they can spend money quite aggressively if the impulse is there. And then the other thing which is key, and I think this comes back to what we know when it comes to addictions, cure might not be the option. It could be just a better quality life is what we're looking for. So again, I think it's really important to understand why the person used the drug and actually go down to almost like your psychiatric formulation of going back to what other things were going on in life that could have been related to this, because the mess isn't just in one area, it can happen anywhere else. So it's very much the harm reduction approach that we use in addictions. So let's move forward regarding myths. I think it's important to acknowledge it's not a trend. I think the reason why numbers are going up is people are more aware. Social media does help. I also think social media is a curse. Individuals do not get help because they have poor motivation. We've got things that potentially get in the way, or as I said, in my mind, that cognitive chaos could be a factor. I've got too many things on my in my mind going on. Alternatively, we may um, be looking for adjustments, and society might say these are special. So again, perhaps it's not special, perhaps it's just a tweak, perhaps it's to change my appointment time to a different time or change my appointment to a different room. Um, Neurodivergent individuals, I would say, do have protective factors because if I told you people die early and I told you a little bit about myself, we've got to have protective factors for us to move forward. So maybe looking at a strength-based approach to identify what is good for that individual and work on some of those, but also looking at what are the risks, as we always do. And as I said to you already, substance use, uh, the substance use won't cure ADHD or autism, but it might make life more comfortable. And I think that's the other thing. It's going back to it's not curative. It's looking for a better quality life. So moving forward, these five principles of human rights, I'm not going to repeat them because I think we all know. I think what becomes more important is that um, we need to look at it from a different lens if we're looking at individuals who come from either different groups or have a disability. We have got articles around the world and in other countries to promote that. I do know politically many countries of the world are shifting more towards the right, but it's important to understand that individuals are individuals. So just to acknowledge that. And for individuals who come across and need help, I think it's important to understand that the organization can become a trusted relationship if the environment is right. It's very easy to feel dismissed in an organization that has its own outcomes. Um, there could be simple things such as, if you help me with planning my appointments for the next month or 2 months or so, that could help. Other types of supplementary groups can help. It could also be looking at what is safe for me and collecting that information safely and documenting it. Being aware that environments can be harsh. I don't know about you, but the two drug and alcohol agencies I worked sorry, their waiting rooms were dark, they were dingy, they were smelly. It was not somewhere I wanted to be. So again, if the waiting room is challenging, why would I hang around? And again, individuals with neurodiversity often have a very high um, level of justice. So if we see any forms of discrimination or things that aren't quite right, sometimes that's the barrier. So sometimes explaining why systems work or are in place may help us not have that knee-jerk reaction. So again, going back to the strength-based approach to help me get through that door. Prevalence is there because I think things are getting better. People are happy to accept that label, but I think we're also better at trying to identify when individuals come into our services. Is their behaviour due to other things? And I think each and every one of us here are aware of having individuals that come into your organisation that have, in the old-fashioned terms, a borderline personality disorder. How challenging that could be. But I think our journey over the past 20 to 30 years have said there are ways in which we can incorporate individuals that may come across as chaotic or unmotivated to help them move forward. But actually, where things don't start feeling right, having other differentials in your head and seeing where we can help them down these alternative routes could be something we're looking for. And as I said before, um, looking at adaptations and adjustments to improve ordinary pathways. We're not looking for anything that's special. We're just looking for something that is has less friction. And trust me, time is not a friction, because having to wait 6 years for a diagnosis, I've had to survive that long. So again, taking things into account, that if time is an issue, tell me where I am on the waiting list. Make contact with me to say, actually, you're still here. We still have you on the list, but you are moving up the list. Other things to be mindful of is listening to an individual doesn't take away from clinical assessments and formulation. It actually makes it better. It makes it more realistic. It makes it more human. So, from Trinity, from work from Trinity, I think it's important to understand that any uh, any data of prevalence is really challenging. So, number one, I can tell you straight away, it's under-recognized. And I would say when it comes to women, they're probably the most challenging group to find, because their symptoms are very different to what you see textbook. So there is now an increased push to identify women of all ages who are neurodivergent. Global population has it less than 1%. But again, I think it's difficult to state how true that is, because access to services is challenging. Um, because of better diagnosis, it can be increasing to 1.5. And in certain higher risk groups, such as young people, where we spend a lot of time with child and adult mental health services, it becomes an easier diagnosis. So as I'm saying, we're not new, we're not getting bigger. I think it's just we're getting more notice because society is starting to understand that and realizing that actually systems may need to change. I'm not going to go over the first two bits, but I think the bit that's important is the behavior when it comes to accessing services, may be something that organizations need to look into. Um, so punitive things, and I apologize if I'm talking about practices that are old. 3 missed appointments means we're going to say goodbye to you. If you don't turn up, we'll just send you a letter. But if I am transient in my place to sleep, that letter's never going to get to me. Um, people have mobile phones, but a phone number, when you see it, you get paralysis. So I'm not going to pick it up because they're going to tell me off. So there's certain things around re getting people into services are a challenge. So that I think we need to consider, how do we re-engage people back into organizations. And actually, one thing that I've realized, which has become more and more prominent, if you see the autistic um, one there, the alexithymia is more and more of an issue, because if you to ask me, can I describe my signs and symptoms? No, because I don't want to know what it feels like. I don't know what anxiety is. I don't know what sadness is. I don't know what lonely is. So some of the words that we look for in psychiatry, I might not have a definition or a understanding what that really is. Another one to take into account is pain scores. So we all know the pain score of 0 to 10, with 0 being no pain at all, and 10 being the worst pain I've ever had. But for someone who's neurodivergent, that doesn't make any sense, because how do I know what this pain is? Because pain is different. If it's toothache, it's different. If it's limb pain, if it's different, how can I quantify it? And so again, it's trying to work out other ways in which you can get the information from individuals like me without me struggling to find either context, words, or um, something that can be translated. And I think the other thing to remember is mixing or coexisting conditions or multiple parts of this does make things more challenging. Okay, so the key bit from Trinity's work, and I apologize if I misrepresent it in any way, what they found was um, many people were undiagnosed. Once you rescreen them in organizations, there was potential diagnostic criteria that where an individual may meet the diagnosis of also having a coexisting diagnosis. The good thing is this was a multinational research paper, and it looked at all the other things. But I think the thing to be mindful of, the numbers are about 1 in 5 of people who used substances may have an ADHD diagnosis. So just to clarify that point, I know one of my friends and actually ex-students is on the call. We had a conversation this weekend about something, and we had a good conversation about the word hyperactivity. And it was about how hyperactivity can be someone not pacing, talking fast. It can be someone who is that energetic, or it can be someone who is quiet, but the hyperactivity is in the brain. So they don't portray in the same way. And I think media portrays it as the classic hyperactive manic, but actually there's many of us who have got mixed or even inattention, where we just appear to be forgetful. We appear to forget big dates, etc. And actually, going back to my statement of having the noise no longer in my head, now I understand why I kept dropping things. Um, Autism. So when I planned this presentation, I was going to focus on autism, because if I was to take the autistic side of me likes control. The autistic side of me likes to understand what's going to happen. So for me, as an autistic individual, the only mind-altering drugs that I can honestly say I have taken in my life, alcohol. I'm not talking about I'm not talking about chocolates and all that. That's not going to count. But so there's alcohol. I had a joint of cannabis once at the age of 17. Didn't like it. Um, caf- um, Caffeine, which for me, I never realized helped me calm down. So that's third one. And the final one is now my stimulants. As someone who's autistic, I don't want to push the boat out too far, because I don't want to lose control. And I think it's important to understand that if an individual who has a primary diagnosis of autism attends an organization, something catastrophic has happened, because it's a big move to say, I like order, I like routine, I like systems, to then go and take a drug that actually takes you to a mind altering place. I know I've got some friends in this in the room as well. So I always tell this story about Christmas times and holidays. When I go to my in-laws, historically, they're quite loud. They're from the north of the UK. They're from Liverpool, so they're quite loud and quite an energetic group, and it doesn't work well with me. And over the past few years, the only way I could survive was by taking a hip flask of whiskey and drinking it throughout the time. And it was a common joke that, yeah, Adrian does it to make it quiet. Now I realized that wasn't true. That was actually medicine that I used to keep it quiet because I didn't know of anything else that would work. So now I can understand how an individual with autism may use drugs to manage a situation. It might not be long term, but it might be to manage a situation. And then perhaps the lack of control comes in later on where chaos happens. ADHD. What the research from Trinity said was the the drug that was used most, so I'm not putting any more weight on that, was benzodiazepines. We can perhaps see why, and I'm not going to put cause and effect, but me talking about having things to calm me down would almost equal that. But less so the other drugs. And you can see predominantly it's benzodiazepines, which tells us um, chicken or egg, cause or symptoms, we don't know. But I think it's important to acknowledge that if an individual comes in, I would say perhaps they've tried to use it as management. So in the green thing, it talks about improving sleep, focus, dampening down sensations, gives me the confidence to access social environments, pain relief, and emotional regulation or emotional managing emotions that I do not want to deal with or I'm not comfortable with experiencing. Again, when it came to the wider looking at gender and sex, predominantly it's benzodiazepines. Um, Alcohol, as it's a readily available drug, seems to be relatively low. So again, I'm not sure how the benzodiazepines are accessed, whether it's through a prescription, whether it's street, whether it's alternative routes, but getting benzodiazepines seems to be a way of managing something. Again, not stereotyping, but again, accessing services may mean actually that individual know that we do know that individuals who are on benzodiazepines potentially have a protracted detox and we will need to be together for a very, very long time. Um, Next one. Autism, again, because the data is small, and as I said, I gave you some of my anecdotal information. There are some reasons why people may. The only thing I can potentially think from my point of view is managing sensory overload or to get confidence to do something big. No, I didn't drink before I came onto this presentation, so I don't do it for that. But the other thing to be mindful of, and I don't think we talk about this enough, is individuals who have neurodiversity also have a high risk of two significant factors, which are neurodivergent shutdown, which can be for minutes, hours, or a few days of where they just need to shut down, reboot, and come back, or burnout, which is not like the old-fashioned nervous breakdown. This individual, over a period of time, would start losing, will start masking more and start losing strength and focus in an activity to the point where actually all they need is time out. Now, unfortunately, society doesn't generally like that, so that people generally plow through. And the problem is, if you've done something wrong and you want to fix it, you want to fix it. So I'm going to work hard at this, which is the complete opposite thing to an individual who may be going through an autistic or neurodivergent breakdown needs. They need the to be not stimulated. They need to rebuild their routine. They need to look for quick wins. They need to look for things to get them back on track. Um, Again, don't assume the things that I've said are true for everyone. Obviously, remember that spiky profile. And then, as I said to you already, the coexisting autism and ADHD. I can honestly say it's difficult to say where that seesaw is because the seesaw moves. Sometimes the ADHD is there, sometimes the autism's there. But the problem is, as I said to you, you've got the person that likes control and the unofficial saboteur who wants chaos, wants new, wants dopamine. And again, I think the research is challenging to identify first autism spectrum disorder, as well as the ADHD and autism. But I think research is going on, and I think it will generally say yes, underrepresented, not picked up properly, overgeneralized. Okay, so when we're developing an assessment on this individual, I think what's important is we need to acknowledge all of these things. I'm aware of time, but I think the blue line tells you we have to go for strengths. Sometimes saying something as simple as, can we go through your forensic history? So you can start plotting those things. Or for someone who hasn't got a forensic history, tell me about your life as an adult. Tell me about your employment. And then what you'll find out is they have things such as they can keep employment for quite a long time, but the reason they left was probably more of an autistic or a neurodivergent thing. So it could be I found the work boring. I met what I needed. Wasn't stimulating for. I moved on. Or I had one disagreement with one person in the organization. My justice level went through the roof. I had to move on. So again, picking up the small things within normal life often helps. And then obviously, I've just spoken about things that aren't great. What about things that are great, and find out what the protective factors were where you haven't done that? What was so good about that job? What was so good about that relationship? Um, Acknowledge self-treatment is not the same as self-sabotage, as I said to you before about symptoms. Acknowledge that, yes, the dependence may have happened, but sometimes coming out of that classical dependence unmasks, as we do in addiction, we know this already, unmasks things that are hidden, and perhaps you need a bit more time to work on that. And please don't look at shame, because shame for someone who is already an outside group within systems, an outside group within organizations, shame is already there. So build it from that strength point of view. And start using positive language. So I'm just picking two from here. So what helped in the short term? What safer support would you need to be put in the future? So going back to those wellness plans that really do help in mental health. Acknowledge again, undiagnosed doesn't mean not having it. Acknowledge that diagnostic overshadowing is key, and do acknowledge that yes, there can be a degree of chaos or problems in waiting rooms and in systems, but again, letting people know what, when, how, what's going on can make things so much easier, but also acknowledge that some systems just don't work. I still don't understand how some organizations do Monday to Friday, 9 to 5. I still hear of people in the USA who've got a long journey just to go and get medication once a day. Those are challenging, and they'll be more challenging for individuals with coexisting conditions. Again, going back to the formulation, look at long-term things. So school, did they finish school? What were their subjects? Why did they leave things early? These little things will help you with that, and then see whether they individuals will identify whether it's to do with safety, whether it's to do with boredom, whether it's to do with unfair rules, unfair justice. So going back to the study again, looking at Ireland, mean age of participants that were identified were 42. 32% had been in services, and 22 were currently in services. So again, I think we do acknowledge services are only picking the mountaintop of what is really going on. Some of that is down to accessibility, some of that is down to readiness, some of that is down to just other pressures. Also, as I said earlier, and just acknowledge that this is purely in Ireland, and we do know even my colleagues in Ireland, when we talk about our health services being similar, they are still very different. So again, national politics and national legislation are very different. Also identified that formal diagnosis was relatively low, screen positive, potentially another 29%. So again, missing people, individuals with a combined ADHD diagnosis, and then autism. So again, I would say if you were to look for the potential untapped area for individuals who may have a neurodiversity, they're on our doorsteps already. But the story of getting there may be very different. Okay, so I think it's important to acknowledge that at this point that services do need to move forward, and we do need to move and be um, helpful. But there are things that we could take into account, such as um, looking at things that could be felt as unsafe, shaming, or inaccessible. Understanding there is a gap between a traditional pathway versus what I may need, as opposed to what I what I may want. It may also be that having assistance, because you might not be able to manage all of my conditions, maybe um, you might need support from third sector or other organizations to help me. So yes, I don't fit in boxes really well. Again, remember, talk about self-treatment. Self-treatment is a way of coping. So again, going back to my whiskey, historically it was to turn those voices down, and I didn't realize those voices were also in my head as well as outside of my head. Understanding that yes, whilst I'm using it to be helpful, it can be harmful, and having explained that to me, that actually to make you better, I may need to make you worse. Unfortunately, if you tell us that and we can work through it, we potentially can move forward. Um, Positive audit C, again, I know audit C is quite a blunt tool, and getting 5 on there is quite easy to manipulate. But remember, it could be the binge drink that flipped me over to above the 5. And remember when I said about self-medicating, we may be self-medicating. And again, if we're using it, don't use that as a factor of you are high risk. Explain and we can move forward. Intersectionality. Jordan's told me today as I was driving home. Today is, I think it's American National Neurodiversity and Pride Day. So somehow this day uh, landed how it is. But I do also want to emphasize that individuals who are going through change often manage their change in different ways. So acknowledge management can be done in other using drugs as well. I am going to rush through because I'm aware of where we are. Work on recovery. Recovery might not be great, but it's just we want to make our life more livable. We don't want to be missed out on any things. We might just want things to help with our sensory load, our building our relationships, managing our money. Those could be the quick wins that we are looking for. Reasons what individuals found as barriers. The Irish report said that predominantly stigma. So remember, there's still self-stigma as opposed to stigma that is on us. Our own issues could be factors as well as the combined history that we may carry. The other thing is we don't know where the organizations are. So again, perhaps other awareness. So try and work on things like that. And as I said, waiting list is relatively low. So um, again, let us know where we are on the waiting list and we're happy. So from a service point of view, especially improvement. So improve access, improve communication, understand what works well for me versus another individual. It looks at acknowledging where mental health is seen as a something that I'm trying to manage versus something that is impacted on me in a negative way. Try and find times that fit. Try and find services that work. Try and find things that work with me. So peer to peer seems to be the new language, and I think peer to peer could be something to help bring people into services and understand that capability to adapt may be down to me because of uh, social structures or personal structures. Understand that structural stigma is a factor, and I'm not going to spend too much time on this, but I think it's important to understand we do need to look at our pathways and any way that we can have service user involvement or co-production in designing services, assessments, rooms, etc. That can only be of benefit. Look at alternative ways of getting us in. So, what works better for me? A phone conversation, a Zoom conversation, or a face-to-face? I don't like forms. Can we do the forms in a different way? Don't be punitive when I don't turn up. Um, I've already mentioned about abstinence. It may not be a goal. Acknowledge my sensory things, so glasses, ear protectors. And we might feel there's no pathway in, or you might feel there's no pathway in. Remember, services can be a protective factor. If I find you as helpful, I'll come back, I'll stay, I'll belong. And ultimately, going back to that peer support, I could be of benefit further down the line. I do have a vignette, but I'm going to jump that. Sorry. Um, Other things to take into account. Consider that individuals who have neurodiversity often have this massive rejection thing where if things go wrong, they feel rejected. They don't like doing things wrong, so they won't make contact. They don't like that punitive side. So it's an instinct which is difficult to work around. So saying something vague such as "Can we meet later on today?" that doesn't help because the head of the individual will be, "What have I done wrong?" Just add more. Can we meet up later today? Because I think we can talk about what we can. These other options that are available. Just give the context because um, putting that in our head will amplify and get bigger. I've already spoke about the formulation, so we've got that down there. But again, help us with the journey. So help me with some predictable landmarks or milestones that I could reach and be realistic. Also, remember, an individual that has autism perhaps has read book to book to book, cover to cover of the service. They'll know the drug, they'll know the side effects. So I think authenticity in the assessment is important. Um, Again, I think it's really important to acknowledge certain things such as what is high risk versus what is manageable risk, what is sensory, what is impulse, acknowledging cognitive load. Small, short bites may be better than one long assessment. I know language is the key, but also try not to blame this on neurodiversity or the drug. Let's try and be open about it that actually an individual may have made mistakes or an individual may have been influenced to do those things using a very strong positive harm reduction approach. Um, Treatment, different routes in. As I said, the organization could be the win. Having somewhere safe could be the win. An organization that will allow me to go in small steps could be the win. An organization that has a room where I can feel comfortable being spoken to could be a win. So again, these wins can be small and actually operationally little to no cost. Bigger issues are for you as staff, we can be challenging. I don't deny that at all. I think understanding and using clinical supervision, and I don't like clinical supervision simply because it's a top-down management thing, but supervision that is restorative supervision, I think is key. One of my colleagues who may be here, I'm not sure, Nikki, who was the ex-president of Ireland, has done a lot of work on vicarious trauma. And I think one of the key things she identified was why do we carry this additional load as a clinician? Are there better ways in which we can manage that emotional um, information? And restorative supervision is so much better than clinical supervision. Also, having an organization which is a lot more open and supportive as opposed to reactive. So, my big leaving bits will be if you build a system that is able to support individuals of various backgrounds, the majority will win. I have said it before in presentations. I don't know where I've said it, but I've read a book from beginning to end from regarding um, radical inclusion. So radical inclusion for someone who hasn't read the book is basically have everyone come in and it's great. Radical inclusion does not believe in that. Radical inclusion states that if you question why you do things that are punitive and understand actually that's not beneficial, and you support those individuals who are perhaps the most vulnerable, the benefits aren't just for the individual, the benefit is for others. So I'll give you a very quick analogy. Many of us live in towns and cities where the supermarket, the schools, the libraries have got a ramp to improve access to buildings. Okay, so I know in Europe it's a European law. So that obviously is to help people with wheelchairs to get in buildings. That's what we're told. The biggest benefactor of those ramps are parents with young children, people with slightly wobbly gaits, etc., children who like to play. Everyone wins. So again, something simple to benefit the person who is in a wheelchair, wide doors, low gradient ramp benefits loads of people. So I think having that in our head is important. Acknowledge gender, sexuality, drug choice is individual, but it could be identity or it could be a mask. So again, acknowledge that. Acknowledge trauma-informed practices. And I'm going to say something controversial, and I do apologize. I think the biggest problem with trauma-informed practice is the clinician. The trauma was experienced by the person in the room. You can only go as fast and as slow as that person will allow you. There are certain things that can be triggering and those that are not. But sometimes the only thing that the person wants is to be listened. So if you go through the history of psychiatry, we know about Freud, we know about Jung, and they've got their principles. Um, Adler stated, when it comes to trauma, sometimes going backwards doesn't help. Working in with the now may help. And his analogy is, I come to see you and I'm dripping wet as I come in, and you tell me why you're wet. Don't tell me I should have packed better. Don't tell me I should have taken the train. Don't tell me I should have had my umbrella. Don't tell me all those things because that's happened. Why don't you come and talk to me and say, do you want a towel? Go and have it, go and get changed upstairs, sort yourself out. That is often more restorative than going too far backwards. So acknowledging sometimes trauma is about the now and working with the strengths of now. It's also about training the organization. And as I said to you before, peer support, but peer-to-peer mentoring works really well. Integrated pathways helps. And I think improving CPD and evidence-based practice can help and should help. Looking at service user involvement, I know in the UK we must have that in most of our service designs. Please ask your patients and service users to be involved in co-production. Otherwise, you're building something for men with men or women in hats on building sites and architects. It just doesn't work. It's shared power, shared governance, and it works so well. Again, language. Language matters. So non-compliance. What was the barrier to get there? Not motivated. Is it because I'm having a bad day and I just cannot get my head to be quiet? Am I relapsing because actually the plan you have isn't working so great, but drug A works better? Am I drug seeking because of what I need to be safe? I'm not engaging in groups because I don't like talking to people. And so I feel embarrassed or I just don't like people. So that could be another one. Um, you're too complex. We're not complex. We're actually, if you build in the logic and understand the why, the questions flow naturally. I know these are human rights and we do go over them all the time. So I think acknowledging that when we look at this, we need to look at a wider population. It will help us design services that are great and are correct. Framework taken from other organizations. I think it's important that we recognize, we inquire, we adapt, we coordinate, and we hold hope because I think lack of hope is a big killer. There are my references here, and I'm going to put my INSA president's hat on. I know there are many people in the room. I know that many of you may not be members, so there is a QR link here to get you access to the website and do join the organization. We are currently using an adaptation of the World Bank, so people from countries get a lower membership and those who have got lower income have better membership. So do consider coming to us. We have some big plans down the line that will be coming your way, and we are hoping to build a great organization that is now built using grassroots initiatives supported by a wider global support network. And from me and the organization, I apologize, this is not my slide, but that format needs to change. Thank you for everyone who turned up and listened and were interested in this presentation. So thank you for the claps. I am quickly going through the talk. So there's nothing in the chat, so that means it's good. Thank you, Addy, for restorative supervision. I think the more I hear about it, I think it is something we do need to consider. Thank you, Angela. Thank you, Sandra. Thank you, everybody, actually. It's a big loving. Are there any questions that people want to ask? I'm aware we're very close to the hour, but are there one or two questions or any statements that people want to make? I think it was recorded, Carla. Okay, so I'm going to out somebody, and I shouldn't do that. So the individual who I spoke to about making sure we ask service users or individuals who are in services about their identity was Robert. Robert's up in the corner from Shatterproof, and me and him have some very good conversations about how can we destigmatize services, individuals, and practices. And I think that was the one conversation we had, which was really quick. And I think we came to the agreement actually there is a lot of push for people to say uh, I'm opiate user or whatever, or I'm an individual with autism. I'm an autistic individual, and sometimes the do-gooders tell me how I should identify. And actually, that's probably the most annoying thing. That ask me what I want or what I prefer, and you've got a quick win already. So I think Robert and I had that conversation. I think it's something we do agree that it might not be the words that you like, but actually it's a word that I prefer. And I think my take home message would be looking at that in a wider context. No, so thank you everybody. I believe the next webinar is going to be on the third Tuesday of July. Jordan, do you have the title? Sorry, I should have warned you on that one.
No, you were fine.
Um,
I don't believe that we have a title yet.
but we do have someone there. They will be getting their slides ready and we'll have it here. Sorry. And also, don't forget that we do these every month. They are part of potentially your learning. And actually, there are many people in the room here who perhaps may not be members, but have got topics of interest, which they can talk from a first person point of view or a research point of view, or even just as I've done, used Pinch Trinity stuff and presented it with my lens on there to give increase awareness. Whilst I'm talking about Trinity, they do have a MOOC out at the moment that is about neurodiversity and addictions. It is free. Philip, how long is it available for? You're on mute.
It's available forever in perpetuity. That's the idea of the MOOC. So
There we go.
it should be available. It's
So
if you do it free, you have to do it 2 hours a week, 3 weeks in a row. Whereas you can pay to get a certificate, and then you have kind of unlimited access to it. But that's just the way it's on Future Learn.
yeah, it's free. It's good. It's insightful. And again, 2 hours a week is not a lot. And I think any way that we can improve our awareness, treatment for individuals from various groups can only be of benefit. So thank you, everybody. I really appreciate the words that are there. It's true. When I took my medication for the first day, it was very much the noise coming off. And as I said to my ex-student who is no longer in the room, it was like when we talk to individuals with schizophrenia, when they talk about the voices, the only thing I can think about it was that noisiness that had now gone. And amazing how that can make you feel so much different, and how we often see relapse as bad in individuals who got schizophrenia, how they are trying to cope and using drugs and alcohol to self-medicate. For me, now makes it sound so logical. So again, my final thank you. Thank you for your time. Thank you for everybody. Thank you, everybody. And we look forward to seeing you in the future. And as I said, the Insta Global and our Insta chapters have got some big plans for the future. So just keep an eye out for our social media, and we'll keep you up to date with anything that's coming through. Thank you.